Welcome back to the deep dive. Let's get right into it. We've got a really interesting set of sources here. Notes, articles, research, all focusing on the absolute foundations of psychiatric mental health care. Our mission today,
Yeah.
to cut through some of the jargon, we're taking these big ideas, the nursing process, therapeutic relationships, how we communicate collectively, even things like anxiety and breaking them down, really distilling them into clear, useful insights for you. Think of this as your shortcut to grasping the essentials.
That's exactly right. And while we'll touch on specific details like, say, the body's stress response or how you talk to a child versus an older adult, the real value, I think, is seeing how all these pieces fit together. They're not isolated concepts. They actually form, well, a whole approach to understanding and supporting people.
Absolutely. And we'll cover some surprising bits along the way, like why asking a family member to interpret is a huge problem, or how long-term stress actually changes your physiology,
Yeah.
and even some of the, well, almost subtle things that make group therapy work so well. So yeah, let's dive in. Okay, so first things first, you need a framework, right? A systematic way to approach care. In mental health nursing, that starting point is the nursing process.
Right. It's the basic structure. Keeps things logical, patient-focused, and, moving towards clear goals. It's usually seen as 5 steps. First up is assessment. This is all about gathering information, everything you can find out. You're collecting subjective data, what the patient tells you, their experiences, feelings, and objective data of that you observe, test results, that sort of thing.
Okay, gathering data. Then what?
Then comes diagnosis. Now, this isn't usually the big medical diagnosis like depression. It's more about identifying the patient's response to health issues, using standardized nursing language, like from Nan to I, pinpointing the problems nursing can actually address.
Got it. So nurse-focused problems.
Exactly. Then you get to planning. This is collaborative. You work with the patient to set achievable goals. The sources stress using SMART goal, specific, measurable, achievable, relevant, time-bound. And crucially, safety is always, always the top priority here. After planning comes implementation, doing the plan, giving meds, teaching skills, running a group, whatever the plan calls for.
In the last step.
The last formal step is evaluation. Did it work? Were the goals met? And if not, why not? You revise the plan based on this. It's a cycle. Oh, and one thing the sources really emphasize, documentation, it's almost like a 7th step. If you didn't write it down, legally and practically it didn't happen. You need it to track progress, ensure safety, everything.
Okay, let's zoom back to assessment. You said subjective and objective data. What key pieces are gathered specifically in a mental health context?
Well, a core piece is the mental status exam, the MSE. Think of it as a snapshot of their psychological state right now. You're looking at their appearance, their behavior, their speech patterns, their stated mood versus their observable effect, their facial expression. You also assess thought process. Is it logical, organized? And thought content, what are they thinking about? Any delusions? Suicidal ideas, really important. Then there's perception, any hallucinations? Cognition orientation, memory. And finally, insight and judgment. Do they understand their situation? Can they make sound decisions?
So the MSE is the now, but the psychosocial assessment digs deeper into their life story.
Absolutely. That's where you get the chief complaint, history of the current illness, past psychiatric and medical history, family history. Crucially, substance use. But it goes broader too. Social history, education, work, relationships. And the sources really hammer home the need to understand their cultural and spiritual identity. That's not optional. It shapes everything. Coping, beliefs, support systems.
And the patient is always the main source for this info.
Always the primary source, yes. You start with them. You might get info from family or records, secondary sources, but the patient's perspective is central.
Assessing different age groups seems tricky. How do you adapt? Child versus, say, an older adult.
Ooh, completely different approaches needed. With kids, you use play, drawing, simple words. You bring parents in. You have to know developmental stages. What's typical for a 5-year-old is way different for a 15-year-old. For adolescents, privacy is huge. You focus on identity, peers. Building trust is key, plus screening for risks. Older adults, you might need to account for hearing or vision loss, maybe cognitive changes. Speak clearly, slowly. Often involving caregivers is important, with the patient's okay, of course. It really shows how assessment has to be tailored.
Okay, this next point feels really critical, especially for assessment language barriers. The sources distinguish interpreter versus translator. Why is that distinction so vital in healthcare?
It's absolutely vital. An interpreter deals with spoken language in real time during interviews, therapy sessions. A translator deals with written documents. And the sources are emphatic. You must use trained medical interpreters, not family members, never family.
Why not family? Seems easier sometimes.
Easier, maybe, but risky. Family might filter things. intentionally or not. They lack medical terminology, it breaches confidentiality. They might have their own biases or agendas. Using a trained medical interpreter ensures accuracy, privacy, professionalism. It's an ethical standard, often a legal one too. It's fundamental for equitable care.
Okay, so we assess, diagnose using nursing frameworks, plan using SMART goals, implement the plan, evaluate if it worked, and document everything. It sounds like a continuous loop.
It really is. It's dynamic, constantly adjusting. And holding it all together are the professional standards. The sources mention the psychiatric mental health nursing. Scope and standards of practice, that document basically sets the expectations. It defines roles, what an RN does versus an advanced practice nurse, an APRN. It guides ethical care, promotes using evidence, ensures competence. It's the rule book, the professional compass.
And that compass guides different levels of action based on your role. RN versus APRN.
Exactly. Basic RN interventions include coordinating care, huge amounts of health teaching, managing the therapeutic environment, what we call milieu therapy, also administering meds, leading relaxation groups, and building that core therapeutic relationship. APRNs, with their advanced training, can provide psychotherapy, prescribe and manage medications, and do consultation work with other health professionals.
So the nursing process gives us the structure, but the how, the connection. That's the therapeutic relationship, right? Chapter 8 stuff.
Yeah.
How is that different from just being friendly?
That's a crucial distinction. A therapeutic relationship has one clear purpose: the patient's healing and growth. A friendship is mutual, about shared interests. In therapy, the focus is solely on the patient's needs and goals, not the nurse's. The style is purposeful, goal-directed, professional, not casual chat. And the goals are therapeutic outcomes, symptom reduction, better coping. It's time-limited, client-centered. Very different from friendship.
What does the nurse need to bring to that relationship to make it work? What qualities?
Several key things mentioned in the sources. Trust is foundational, built through consistency, honesty. Empathy, understanding the patient's world as if it were yours, but staying objective. Genuineness, being authentic, not playing a role. Also, positive regard, accepting the person unconditionally, even if you don't condone certain behaviors. Maintaining clear professional boundaries. And active listening, truly hearing and validating their experience.
Boundaries. That word comes up a lot. It sounds important, but maybe a bit fuzzy. Can you clarify the types and what crossing them means?
Yeah, it's vital. They are physical boundaries, space, touch; emotional boundaries, staying objective, not oversharing your own problems; social role boundaries, not becoming friends; avoiding business deals. The sources distinguish a boundary crossing, maybe a brief, acceptable deviation, like a reassuring touch in a crisis, if justified and documented from a boundary violation. Violations are harmful or exploitative. Accepting large gifts, excessive self-disclosure that shifts focus to the nurse, any romantic or sexual involvement. And the sources are crystal clear. Sexual misconduct is always a violation, always unethical, always illegal. No gray area there.
What about those tricky psychological things, transference and countertransference? They sound like boundary minefields.
They can be. Transference is when the patient unconsciously projects feelings from past relationships onto the nurse, like, you remind me of my critical father. Countertransference is the nurse doing the project, maybe over-identifying with the patient because they remind the nurse of someone. Recognizing these is key to maintaining objectivity and not letting them distort the relationship or blur boundaries.
And culture impacts all this too, right? How we relate.
Massively. Avoiding ethnocentrism, thinking your culture's way is best, is crucial. Your values, the patient's values, they influence everything. Communication styles, ideas about family, health beliefs. You have to be aware of that to build trust effectively.
Peplal's phases, that sounds like a way to map the journey of this relationship.
It's a helpful model, yeah. Pre-orientation is the nurse prepping, reviewing info, self-reflection. Orientation is the beginning, introductions, building trust, setting goals, defining the relationship. The working phase is the main part, tackling problems, implementing interventions, making progress. And termination is the ending, reviewing progress, managing feelings about ending the relationship, planning for the future.
Okay, let's shift to communication. Chapter 9. It's the tool we use in that relationship, more than just talking, clearly. What about models?
Right. There's a simple linear model, sender to receiver, like a lecture. But therapeutic communication is better described by the transactional model. It's two-way. Both people are sending and receiving messages simultaneously, influencing each other through feedback, verbal and nonverbal, like our chat right now.
What gets in the way of good communication? What are the barriers?
Lots of potential barriers. The sources group them. Personal factors like high anxiety in either person, language differences, environmental factors, noise, lack of privacy, uncomfortable room, and relationship factors, power imbalances, lack of trust.
Verbal versus nonverbal. It's amazing how body language can say the opposite of our words.
Isn't it? Verbal is the words, intentional. Nonverbal is body language, tone, expressions, often unconscious. And it often carries more weight, especially for emotions. If the verbal and nonverbal don't match, people usually trust the nonverbal more.
And nonverbal cues are so culturally bound. Eye contact, touch.
Huge differences. The sources mention examples. Some Asian cultures might avoid direct eye contact with authority as a sign of respect. Touch might be less common. Some Middle Eastern cultures use intense eye contact. Same-gender touch is common. Western cultures often value direct eye contact. Touch is more moderate. Misreading these cues due to cultural ignorance, that can really damage trust, cause offense, lead to misunderstandings. You have to be sensitive.
So how do we actually do therapeutic communication? Techniques that help versus ones that hinder.
Key therapeutic techniques include active listening, showing you're fully present. Open-ended questions, tell me more about, instead of yes-no questions. Restating or paraphrasing so it sounds like you're feeling, confirms understanding. And silence, giving space for reflection. It can be powerful.
And the pitfalls, the non-therapeutic ones.
Things to avoid. Giving advice, it takes away their autonomy. Minimizing feeling, don't worry, it'll be fine, and validates their experience. Asking why, questions often sounds blaming. And changing the subject abruptly when things get tough, it shuts them down.
What about the physical setup? Does that matter for a good interaction?
Definitely. The source is just letting the patient set the pace. Find a setting that's quiet, private, safe. Sit at eye level, about 3-6 feet apart, close enough for connection, far enough for comfort. And avoid physical barriers, like sitting behind a big desk. It feels more equal. And your own attending behaviors matter. Culturally appropriate eye contact, open posture, calm facial expression, gentle tone of voice, using silence well, it all signals you're engaged.
Clinical supervision gets a mention too. Why is that important for nurses?
It's crucial for professional growth and well-being. Supervision provides a space to discuss difficult cases, process your own emotional reactions like countertransference, and get guidance on ethical dilemmas. It improves patient care through accountability and helps prevent burnout by offering support.
Okay, let's shift from the connection between people to what's going on inside stress and anxiety. Chapter 10 covers stress. We all feel it, but what's actually happening physiologically, short-term versus long-term.
Right. In the short term, you get that classic fight or flight response. Sympathetic nervous system kicks in, heart races, blood pressure rises, breathing quickens, muscles tense. You get a surge of adrenaline and glucose for energy. It's adaptive for immediate threats. But the sources really stress the danger of long-term chronic stress. Constant activation wears the body down. It suppresses the immune system, raises cardiovascular risk, messes with digestion, disrupts sleep, throws hormones out of whack. It worsens almost any chronic condition. It's damaging.
The sources mention two classic models, Cannon's fight or flight and Selye's general adaptation syndrome, GAS. What's the difference?
They focus on different timescales. Cannon's is about the immediate, acute reaction, that sympathetic nervous system jolt. Selye's GAS looks at the response to prolonged chronic stress. It involves the endocrine system more broadly and has 3 stages. Alarm, the initial shock, fight or flight. Resistance, the body tries to adapt, cope, stay activated. And finally, exhaustion, resources get depleted. Vulnerability to illness increases significantly.
But it's not just the stressor, right? People react differently. What influences our response?
Exactly. The mediators of stress response are key. How you perceive the event, threat versus challenge makes a huge difference. Your underlying temperament. Social support is a massive buffer. Strong connections help immensely. Support groups offer shared understanding. Culture influences how stress is expressed and what coping is acceptable. And spirituality or religion can provide meaning, hope, and coping mechanisms for many people.
How do we even measure stress? There's a questionnaire mentioned.
Yeah, the recent Life Changes questionnaire. It assigns points to different life events, marriage, job loss, moving, etc. You add up the points for events in the past year or so. It gives a rough estimate of stress load. Scores around 150-200 suggest mild risk, 200-300 moderate, and over 300 a high risk of stress-related illness. It's a way to quantify that accumulated pressure.
So how do we help people manage it? What techniques work?
Lots of good relaxation techniques. Deep breathing is foundational. Consciously slowing, your breath activates the parasympathetic system, the rest and digest response. The source gives that simple 4-2-6 count. Inhale 4, hold 2, exhale 6. Others include progressive muscle relaxation, guided imagery, meditation, mindfulness practices, even biofeedback, where you learn to control physiological responses.
What about tackling the thoughts that fuel stress? Cognitive approaches.
Absolutely critical. Cognitive techniques target the thinking patterns. Cognitive reframing means identifying those negative, stress-inducing thoughts and challenging or replacing them with more balanced ones. Journaling helps spot patterns. Positive self-talk counters negativity. And goal setting, even small steps, builds a sense of control. These boost resilience.
Okay, let's move from general stress to anxiety disorders, chapter 15. It's not just one thing, right? There are levels.
Right, Piplaw's 4 levels are really useful. Mild anxiety is normal, increases alertness, helps performance. You're restless but focused. Moderate anxiety narrows your focus to the immediate concern. Problem solving is harder. You get physical signs, tension, pounding heart, maybe some trembling. Severe anxiety really shrinks your perceptual field. You might focus on one tiny detail, can't process much else. Problem solving is poor. Physical symptoms are worse: dizziness, nausea, hyperventilating. And panic is the most extreme. Total loss of control, overwhelming terror. Perceptual field might close entirely. Thinking is disorganized. You might feel unreal or be unable to move or become hyperactive. Understanding these levels guides how you intervene.
Defense mechanisms come up too. How do they relate to anxiety? Are they always bad?
They're unconscious ways we protect ourselves from anxiety. Not inherently bad. They can be adaptive, helpful temporarily. But they become maladaptive if overused or if they block dealing with reality. For instance, denial might be adaptive briefly after a shock, but maladaptive if you deny a serious diagnosis long term. Displacement, punching a pillow, adaptive versus yelling at your kids, maladaptive. Sublimation, channeling anxiety into exercise, is usually adaptive. The issue is when they prevent growth or problem solving.
What are the common anxiety disorders the sources mention? Key features.
Okay, there's separation anxiety disorder, specific phobia, intense fear of an object situation, social anxiety disorder, fear of certain embarrassment, panic disorder, recurrent unexpected panic attacks, agoraphobia, fear of places where escape might be hard, and generalized anxiety disorder, GAD, that persistent, excessive worry about lots of things.
What puts someone at risk for these?
Several factors. Genetics play a role. Trauma history is significant. Neurobiology differences in brain circuits like the amygdala. Substance abuse can trigger or worsen anxiety, chronic medical issues, and certain personality traits, like high neuroticism.
So for nursing care, what are the main concerns, the priority diagnoses?
Priorities often focus on safety and immediate distress. So, anxiety itself, obviously, ineffective coping, feelings of powerlessness, and critically, risk for injury, especially if someone is in severe anxiety or panic and might not be thinking clearly.
And what are we aiming for? What are the treatment goals or outcomes?
We want the patient to be able to say they feel less anxious, to demonstrate they can use coping skills to participate in therapy, and to have improved functioning, like better sleep, measurable improvements.
What can nurses do? Basic interventions.
Key things include using a calm, reassuring presence, encouraging them to talk about their feelings, teaching and practicing relaxation, that deep breathing again, helping identify triggers and effective coping strategies, promoting physical activity, staying with them during severe anxiety or panic to ensure safety.
What about medications and therapies?
Meds often start with SSRIs or SNRIs. Benzodiazepines might be used short-term for severe symptoms, but carefully due to dependence risk. Buspirone is an option for GAD. Beta blockers can help physical symptoms. Therapy-wise, CBT, cognitive behavioral therapy, is really the gold standard. Exposure therapy is key for phobias and sometimes panic-agoraphobia. ACT, acceptance and commitment therapy, and MBSR, mindfulness-based stress reduction, are also effective.
Okay, shifting slightly to OCD and related disorders. Still anxiety-related but distinct, right? The source mentions abnormal selective overattention.
Yeah, they involve repetitive thoughts, obsessions that cause anxiety, and/or repetitive behaviors, compulsions the person feels driven to do to reduce that anxiety. That selective overattention points to the intense focus on the obsession or the need to perform the compulsion perfectly. The main one is OCD itself. Related disorders include body dysmorphic disorder, preoccupation with perceived flaws, hoarding disorder, trichotillomania, hair pulling, and excoriation disorder, skin picking.
Risk factors similar to anxiety.
Some overlap. Genetics, definitely. Brain pathways involving serotonin seem involved. Stressful life events can trigger onset, sometimes childhood trauma.
What are the nursing priorities and goals for OCD?
Diagnoses might include anxiety, ineffective impulse control for compulsions, impaired skin integrity if picking, pulling, and often chronic low self-esteem. Outcomes focus on identifying triggers, reducing ritualistic behaviors, improving self-image, and learning alternative coping skills.
Interventions sound tricky, especially with rituals. You can't just tell them to stop, right?
Absolutely not. Abruptly stopping rituals usually increases anxiety dramatically. The key is gradual reduction, supporting them as they resist the urge. Help them develop alternative coping methods. Providing structure and routine can also help reduce the underlying anxiety. Meds often involve SSRIs, but usually at higher doses than for depression. Clomipramine, a TCA, is also used. The main psychological therapy is CBT with exposure and response prevention, ERP.
ERP, what's that?
It involves gradually exposing the person to the feared thought or situation, the exposure part, while helping them resist performing the compulsion, the response prevention part. It's tough but very effective. Habit reversal training is used for pulling picking. Group family therapy can also be supportive. The sources do note fewer specific FDA-approved meds for the related disorders compared to OCD itself.
Okay, let's look at care delivery beyond one-on-one. Therapy Group, Chapter 34. How does being in a group actually help people?
It's fascinating. Irvin Yalom identified key therapeutic factors. These are the active ingredients of group therapy. Things like universality, realizing I'm not alone. Others feel this way too. That's huge. Altruism, the benefit you get from helping others. Installation of hope, seeing peers improve, gives you hope. Imparting information, learning from others' experiences and the leader. There's also corrective recapitulation, kind of replaying and fixing old family dynamics in the group. Learning socializing techniques. Imitative behavior modeling, healthy coping, interpersonal learning, getting feedback on how you come across, group cohesiveness, that sense of belonging, and catharsis, safely releasing pent-up emotions. It's a powerful mix.
The sources mention group content versus group process. What's that about?
Good distinction. Content is what is being talked about, the topics, the words. Process is how it's happening, the dynamics, the nonverbals, who talks to whom, the emotional undercurrents. A good leader pays attention to both, but understanding the process is often key to unlocking deeper issues.
Do groups develop in stages, like relationships?
Yes, typically. There's an orientation phase forming, figuring out rules, testing the waters. Then the working phase, more trust, deeper work, conflict might emerge and get addressed. And the termination phase ending, reflecting, saying goodbye, managing those feelings.
People take on different roles in groups.
They do. Task roles help get the job done. Initiator, information seeker. Maintenance roles keep the group cohesive. Harmonizer, encourager. And individual roles meet personal needs but can hinder the group. Aggressor, blocker, monopolizer. Leaders need to manage these roles.
What kinds of groups do nurses typically lead?
RNs often lead psychoeducational groups teaching about illness, meds, medication education, coping skills, symptom management, stress management, health education. Also therapeutic community meetings on inpatient units. They might facilitate support self-help groups. Formal psychotherapy groups usually require APRN level training.
How does the leader's style affect things? Autocratic, democratic, laissez-faire?
Style matters. Autocratic, leader controls everything, can be good in a crisis but limits member growth. Democratic, shared decision-making, fosters collaboration but can be slower. Laissez-faire, hands-off, might work for mature groups but can lead to chaos if members need more structure. Often, flexibility is best.
Confidentiality in groups feels like a big challenge. Can't be guaranteed like one-on-one, can it?
That's a critical point. The nurse leader has professional confidentiality, but the members are only asked to maintain confidentiality. They aren't legally bound like the professional. Nurses must make this clear up front. There's always a risk of breaches by members which can destroy trust. Emphasizing mutual respect is key, but the limitation has to be acknowledged.
How do you handle difficult members? The person who talks nonstop or the one who says nothing?
Strategies exist. For the monopolizer, gently interrupt, redirect, invite others to speak. For someone disruptive, calmly reinforce group rules, perhaps address it directly but respectfully. For the silent member, invite participation gently. What are your thoughts on this? But don't force it. Sometimes silence needs to be respected too.
All right, final section. Integrative Care, Chapter 36. Combining different approaches. Let's clarify the terms. Complementary, alternative, integrative.
Good place to start. Complementary means using a non-mainstream approach together with conventional medicine, Itsiki acupuncture alongside pain meds. Alternative means using it instead of conventional medicine, example herbs instead of chemo, generally riskier. Integrative care is the preferred model now. It combines conventional and evidence-based complementary therapies in a coordinated, holistic, patient-centered way, using the best tools available safely.
Are these therapies becoming more common? What are the trends?
Definitely trending up. More people, especially with chronic issues, are seeking holistic options, wanting more control over their care. Healthcare systems are slowly integrating them more. Research is growing, though still lagging for some therapies. People use them for wellness, stress, symptom relief, sometimes dissatisfaction with conventional options. The nurse's role is huge. Assess use, educate on safety evidence, advocate, help integrate safely,
How are they categorized?
often by domains. Natural products, herbs, vitamins, supplements. Big caution here. Potential interactions with meds. Assessment is vital. Mind and body practices yoga, meditation, acupuncture, tai chi, guided imagery. Very relevant for mental health. Other integrative approaches as a catch-all, traditional healers, energy therapies, etc.
And you give some examples used in mental health.
Sure, the sources mentioned. Acupuncture for anxiety, depression, withdrawal, aromatherapy for stress, sleep, guided imagery for anxiety, trauma. Meditation mindfulness, widely used for stress, mood regulation. Therapeutic touch Reiki for relaxation. Expressive therapies like art or music for emotional expression.
Why is education about safety and evidence so crucial here? They're not all regulated like drugs.
Exactly. That's a major point in the sources. Not everything natural is safe or effective. Many supplements aren't FDA regulated for quality or dosage. Huge potential for interactions, especially herbs with psychiatric meds. Patients need unbiased information to make informed choices. The nurse needs to assess what they're using, educate them about risks and benefits based on evidence or lack thereof, and point them to reliable resources like the NCCIH. It's about safe, informed integration, not just letting anything go.
Wow, okay. That was definitely a deep dive. We covered a lot of ground from the basic nursing process framework to the nuances of relationships and communication,
Yeah.
then understanding stress, anxiety, OCD, the dynamics of groups, and finally this growing field of integrative care. Really gives you a sense of the layers involved.
It does, and you see how they all connect, right? You need the process, but you also need the connection, the communication skills, the understanding of internal states, and a broad view of healing options. It's all intertwined.
So what's the takeaway for you listening? Whether you're learning this for practice, trying to understand someone else's journey, or just curious, these principles offer a solid foundation. They show the thinking behind quality mental health support.
I think it boils down to this. While we have structures and techniques, the real core of psychiatric mental health care is that therapeutic use of self. It's about meeting people where they are with skill, empathy, and genuine presence.
Absolutely. So here's a final thought to chew on. Considering how much culture shapes our experience and expression of things like anxiety, and with this rise in diverse therapies, how do our standard healthcare approaches need to keep adapting to be truly person-centered and effective for everyone, everywhere? Something to think about until next time.